The following podcast is part of a certified educational activity titled From Early Detection to Disease Modification, Personalized Approaches to Biomarker Testing and Therapeutic Management of Alzheimer's Disease. Access the entire activity and complete the post-test at peerview.com/NMQ860. Downloadable slides and practice aids are also available.
Hello, I'm Marwan Noel Sabah. I'm the Moreno Family Chair for Alzheimer's Research, Vice Chairman for Research, and Professor in the Department of Neurology at the Barrow Neurological Institute. Our program today is From Early Detection to Disease Modification, Personalized Approaches to Biomarker Testing and Therapeutic Management of Alzheimer's Disease. What are the gaps that we identify and how we're going to address them? So if you actually look at the healthcare gaps, there's gaps both in detection and diagnosis. The Alzheimer's Association, CMS, and American Academy of Neurology all recommend early detection and diagnosis of AD, at least in the mild cognitive impairment stage. Nevertheless, there are several studies indicating that up to only 15% of patients are ever diagnosed in MCI with MCI, and 99% of primary care physicians underdiagnose MCI. Even when we advance to more severe stages, many patients with dementia go undetected and uninformed of their diagnosis, with up to 40% of patients with mild dementia going undetected by primary care physicians, and 55% of individuals suffering from Alzheimer's disease are never told that they have the disease. Prior to the advent of disease-modifying therapies, PET and fluid biomarkers were not routinely used in the diagnosis of mild cognitive impairment or Alzheimer's disease dementia. However, when patients did receive biomarker testing, it was shown to change the management in up to 60% of patients through a study called the ARIA study, showing that when physicians had amyloid PET, they changed their management and diagnosis up to 60% of the time. So our goals today are to improve your diagnostic precision for early-stage Alzheimer's disease by leveraging validated biomarkers and clinical assessment tools. Enhance your ability to identify patients with early-stage Alzheimer's disease who might benefit from new disease-modifying therapies, and sharpen your skills in detecting and managing amyloid-related imaging abnormalities in patients receiving disease-modifying therapies for early-stage Alzheimer's disease. Let's start our discussion with a patient. This is our first case. This is a 69-year-old female with cognitive symptoms who's referred to a memory disorder specialist like myself. Her name is Marcia. She was presented to her primary care physician about 9 months ago for trouble with word-finding difficulty and multi-step sequences. Her medical history is for hypertension, type 2 diabetes, both well controlled on medications. Her basic workup, including B12, TSH, CBC, LFTs, lipids, electrolytes, and homocysteine are normal. The mini-mental is 26 out of 30. The PHQ-9 shows mild symptoms of depression and anxiety. Her functional assessments questionnaire, the FAQ, shows that she scores 3 out of 30, which is minimal impairment, with some difficulty balancing a checkbook, but she still does it on her own. MRI of the brain shows mild to moderate parietal lobe atrophy, minimal bilateral frontal lobe atrophy, mild bilateral hippocampal atrophy, and mild to moderate small vessel ischemic change. So the physical neurological exam are normal. There's no evidence of Parkinson's, stroke, tumor, hydrocephalus, B12 deficiency, thyroid disorder going into the evaluation. So we know what she doesn't have. The primary care physician orders Marcia to go to a memory disorder specialist for further workup. Based on Marcia's medical history, cognitive and functional assessments, and brain imaging results, her preliminary diagnosis would be mild cognitive impairment. And mild cognitive impairment and dementia are categorical definitions, one with retained independence, because she's still independent, and so that would by definition be mild cognitive impairment, and dementia is lost independence or functional dependence due to a cognitive issue. And the challenge now is to determine the etiology of her mild cognitive impairment, and the etiology we would suspect due to Alzheimer's disease. So the specialist would actually recommend biomarker testing to determine if mild cognitive impairment is indeed caused by Alzheimer's disease. So the reason to say this to you is that this is a moment in our practice that we are changing the approach. All of you learned, all of you, including me, that you could only diagnose Alzheimer's disease with an autopsy. That comes from the 1984 NINDS-ADRDA criteria. And we always took the exclusionary approach to management of Alzheimer's or diagnosis of Alzheimer's by excluding other pathology. All the data suggests it's very, very, very unreliable, and physicians don't feel comfortable making a diagnosis. What is changing now is that instead of just going for a phenotypic description of Alzheimer's disease, meaning forgetfulness, misplacing your glasses and keys, getting lost, repeating yourself, that's the phenotypic description. We are now going for a biomarker description of Alzheimer's. And so the transformation now is to go for a biomarker diagnosis of Alzheimer's disease with a new staging criteria called the ATN criteria. A stands for amyloid, T, tau, and N for neurodegeneration. And so we are now defining Alzheimer's disease as a biological disease, not a clinical disease. So instead of just spending our time worrying whether they misplaced their glasses and keys and forgetting, we are now spending our time trying to say, is there symptoms related to an underlying disease? And so to be Alzheimer's disease, you must be A, amyloid positive, and then you would have tau and neurodegeneration, or tau or neurodegeneration, or none of the above. To be clear on this, you can have a neurodegenerative progressive neurological disorder that's not Alzheimer's, and that would be amyloid negative. So I want to tell you that it's important that you understand the redefining of Alzheimer's as a biological disease, not a clinical disease. This has actually been redone even in 2024 with ATX criteria. And importantly, on the right-hand side of this slide, you see that the patient biomarkers or the biological changes precede the onset of clinical symptoms. So on the right-hand side is the clinical symptoms. On the left-hand side is the biomarker changes over time. We actually now have multiple criteria. We call ATN now in 2024 ATX. X stands for other things. So amyloid, tau, and N. ATX would be neurodegeneration, that's N. I is inflammation, V is vascular, and S is synuclein. So we are going to see that X growing to be multiple other things, but you need amyloid. You would expect to see tau changes, but you can see other things as well, including neurodegeneration, inflammation, vascular, and synuclein. And we now have biomarkers available. And what you need to understand, and this is super, super important for you in this audience to understand, is that these are not research biomarkers. These are clinically available biomarkers. You can order them on the PET scan. You have the amyloid PET and tau PET. We're doing a lot more of that than FDG PET. So amyloid PET would be for checking for amyloid, tau PET for tau. Amyloid PET is covered by Medicare, tau PET is not. We now have CSF testing to look at 42 to 40, 181, and 217 in the CSF. We now actually have plasma biomarkers as well. My point is that we actually now have more and more biomarkers available to us, and we're now even seeing the emergence of plasma blood-based biomarkers in our clinical practice. So to be A positive, you must be amyloid positive either on CSF or PET. You can actually use plasma to be amyloid A42 to 40, and you would expect A beta 42 to 40 to go down, not up. And CSF would go down, and amyloid PET would be positive in a binary positive or negative. So one of the core biomarkers to define Alzheimer's disease is the presence of amyloid as defined by amyloid PET, CSF, and probably tau. And we're now looking at multiple ratios, including p-tau 181 to A beta 42 or total tau to A beta 42. These are approved, as you see in the red boxes, and this would be considered appropriate by Medicare and reimbursed by Medicare. Now, I'm a big user and big fan of amyloid PET. I want you to look at the upper left-hand corner. The reason I say this too is that amyloid PET in clinical practice is supposed to be read on the gray scale, meaning the upper left-hand panel. And what you see is that the gray matter and the white matter are very, very clearly differentiated from each other. That's a negative scan. We read in practice a negative or positive scan. It's a binary scan in clinical practice. In research, we actually have quantification tools, including SUVR and Centiloids, but in clinical practice, we use a binary, positive or negative. On the upper right-hand scan, you see there's a blurring of the gray matter and the white matter. That's a positive scan. And what you understand here is that amyloid PET has excellent sensitivity, 88 to 90%, sensitivity and 80 to 90% specificity. So it's very, very reliable as is compared to PET to autopsy studies. And we know that these can even precede onset of clinical symptoms. And we now showed in the IDEA study, as I mentioned earlier, it can change clinical practice, management, diagnosis, discussion with patients, and treatment, 60% in mild cognitive impairment and 63% in dementia. So we now also have in our toolbox CSF panels. They're available, they're reliable, they're accurate, they're highly diagnostic with excellent sensitivity and specificity, and highly predictive. So when you look at multiple cohorts looking at amyloid and tau, what you see is that it correlates very, very well with amyloid PET, and the concordance is about 90% with amyloid PET. When you look at its positive predictive value and the negative predictive value, you see that the biomarkers actually have areas under the curve about 86%. When you just look at amyloid, and when you look at total tau, it's 81%. When you look at p-tau, it's 0.84. When you look at a ratio of p-tau to A-beta-42, the AUC is 0.94. So ratios, whether you're looking at t-tau to A-beta-42 or p-tau to A-beta-42, are highly, highly accurate and have very good AUCs. Plasma biomarkers are really starting to enter the conversation, and there's a lot of discussions about plasma biomarkers. The questions that we're often being asked is, are they ready for prime time? Are you ready to use them in practice? What you need to know is that plasma biomarkers are actually available, and Quest, LabCorp, C2N have assays now commercially available, and we have them in our clinic. They have blood-based biomarkers, which would be things like A-beta-42 to 40, p-tau-181, p-tau-217, and even neurofilament light. The money test that everybody's focused on is p-tau-217, which is the one that seems to have the ability to have an accuracy over 90%. So then the question you're asking is, what do you order and when do you order it? I want to tell you, in my practice, I actually used the plasma testing as a gating tool. And as you know, boils down to codes. Everything is a code. So the question then is reimbursement. And so I use it for the negative predictive value. So if the tests are normal, I don't go on to secondary testing. But if the tests are abnormal, I do go on to secondary testing, either amyloid PET or CSF testing. And this is super, super important because amyloid PET can be covered by straight Medicare, a tau PET not. And some insurance companies will pay for amyloid PET, some will not. And so as an alternative, I'll use CSF testing. People say to me, gee, that seems awfully invasive. Number one, it's covered. Number two, it is very, very accurate. I think I've made that argument. Number three is often we do it in our own practice or we send to interventional radiology. Number four is people think it's invasive, but the truth is if they have meningitis, encephalitis, and other neurological conditions, we're doing lumbar puncture. So there's no reason to not do a lumbar puncture. And so it seems to be a little bit arbitrary. Each of them have their advantages and each of them have their limitations. There are three amyloid PET tracers, fluorobeta-peer, fluorobeta-beta, and flutamidamol. They are FDA approved, and CMS has been paying for them in a limited manner for the last 6 to 8 months. We now have tau PET, which checks for tau aggregates. CMS not paying for it quite yet. And you see now multiple assays available, including CSF, Alexis, and LumiPulse. And then you have a lot of plasma assays now, including genotypes, neurofilament light, 42 to 40 ratio, p-tau-181, and others. So then the question is, which biomarker test is appropriate for this patient? We said clinically she has a mild cognitive impairment suspected due to Alzheimer's disease. We referred to the specialist, that would be somebody like me, and what test would I order? I can tell you if I can get it paid for and code-wise, I might start with the plasma testing, A-beta-42 to 40, p-tau-181, neurofilament light, and p-tau-217. However, I might, if there's strong clinical suspicion, skip that and go straight to amyloid PET or CSF testing based on what I can get reimbursed. So to discussing alternative options for biomarker testing, Marcia selected for amyloid PET imaging. So let's talk about our next case. This is a 57-year-old female who has received a diagnosis of mild cognitive impairment due to Alzheimer's disease. This is Heather. She is diagnosed with MCI and positive AD biomarkers. She is, unfortunately, an APOE4 homozygote, means she has 2 copies of the APOE. And the question then is she eligible for amyloid-related therapies? She has a very strong family history, and she has no MRI exclusions. This is very important. So the reason we're now moving into the therapeutic considerations is that we have to select our patients very carefully. The use of the disease-modifying therapies, they are now approved, and you have 2 of them available, the monoclonal antibody lecanemab and the monoclonal antibody donanemab, now approved and selectively reimbursed by insurance and Medicare. And you understand that they do 2 things at the same time. They are the first DMTs, so they hit biological endpoints of removing amyloid. They do it remarkably well, to the point where most patients by the end of the treatment have no amyloid left. And clinically, they slow the rate of decline on cognition, on function, on quality outcome measures. And so this is now shown to be the first time that we can show that we're slowing the rate of decline to the point where we're saving a patient half a year expected savings compared to placebo. And there are secondary benefits, including lowering of other biomarkers, including tau, neuroinflammation, and neurodegeneration.
On January 6, 2023, the U.S. Food and Drug Administration approved lecanemab via the accelerated approval pathway for the treatment of mild cognitive impairment or mild dementia due to Alzheimer's disease. The prescribing information for lecanemab includes a warning for amyloid-related imaging abnormalities, or ARIA. ARIA usually does not have symptoms, although serious and life-threatening events rarely may occur. The most common adverse events with lecanemab were infusion-related reactions, headache, and ARIA.
However, you have to be careful when you select your patients. First thing you have to do is they have to have amyloid. Either they have amyloid or they don't have amyloid. If patients who do not have amyloid confirmed by CSF or PET, you would not give a monoclonal antibody. 2 is they have to be mild cognitive impairment or mild dementia. If they're moderate or severe dementia, that excludes them. If they're too impaired, that excludes them. If their MoCA is low, that excludes them. If their mini-mental is low, that excludes them. And after you get those basic criteria, you have to look at their other criteria. 1, if they have a pacemaker and they cannot get an MRI, you cannot allow them to get it. You must do MRIs. CT is not a good proxy, so you must do MRIs because the patient assessment requires frequent MRIs. 2 is if they have at baseline a lot of microhemorrhages or areas of superficial siderosis, that would suggest that the patient should not get a monoclonal antibodies, and especially if they have lacunar infarcts, etc. 3 is that there are restrictions on patients who have anticoagulations. It's not an absolute contraindication, but it is something you need to think about, and other conditions as well. Now, part of the issue that you must do when you're assessing your patients is for appropriateness. APOE genotyping has been around for 25 years as a cardiac test, but it was considered kind of off limits and taboo in the Alzheimer's space for genetics because they thought that disclosing APOE would cause harm. That's being rethought completely from top to bottom, and we now use APOE genotyping as a proxy risk assessment of complications, which are known as ARIA. So we know that the ARIA risk of amyloid-related imaging abnormality does very much depend on your APOE genotype status, and so we'll kind of dig into this a little bit more. There are 2 kinds of ARIA, ARIA-E, vasogenic edema, and ARIA-H is microhemorrhages. The rate of ARIA depends on your APOE genotype. So if you're an APOE4 non-carrier, your risk of ARIA is 5% with lecanemab, 12% for donanemab. If you're a heterozygote, meaning 1 copy of the APOE genotype, your risk of ARIA is 15% with lecanemab and 24% with donanemab. And if you're an APOE4 homozygote, meaning 2 copies of APOE4, your risk is 33% with lecanemab and 44% with donanemab. And so this is important because people have to decide whether it's safe and appropriate based on their genotype. You have to look at the dosing of the anti-amyloid therapy. You must look at the fact that most ARIA events tend to occur in the first 6 months. and you have to really think about it if they have evidence of cerebral amyloid angiopathy, and that can be determined by baseline microhemorrhage rates. So I would tell you that anti-amyloid treatments should be gone through with shared decision-making. And when I talk to my patients about the monoclonal antibodies, I talk about what are the three options. One is symptomatic drugs only. Two is symptomatic drugs plus disease-modifying therapies, and talk about what you achieve from each one of those. And three is symptomatic drugs plus clinical trials. A lot of patients run toward the DMTs, and a lot of patients run away from the DMTs. So it's important that you take the time to sit and discuss these with them and set expectations. To be clear on these, the DMTs, the ATTs, do not make people better. They make them less worse. So after you've selected the patients very carefully, you have to be able to articulate, what are you getting out of this? You're clearing out the amyloid, you're slowing the clinical progression, but it doesn't make you better. It requires intravenous infusions. It's expensive, it's costly, it's involved. They have to come to infusion centers. There can be risks of ARIA, and there can be infusion reactions. And it is not a cure, but it has been known to have some benefit. So these are the things you need to talk about in shared decision-making. We'll come back to Heather. She's a homozygote. I think you could pull the trigger on it. I will tell you that I'm a little scared to give Heather anti-amyloid therapy because she's 2 copies of the E4. I said the ARIA risk is 33% with lecanemab and 44% with donanemab. And what we did in a shared decision-making way, after weighing the risks and benefits of treatment and discussing the alternative options, she decided to pursue the anti-amyloid therapies. Let's talk about our next case. This is Kendrick, a 74-year-old male who has received a diagnosis of dementia due to Alzheimer's disease, considered to be mild. Remember, dementia means he's no longer independent, and he has cognitive decline severe enough to cause functional impairment. So his MoCA is 18. That puts him in the late mild stage. CSF it consists with AD pathology, ApoE4 non-carrier. He is on anticoagulants for his atrial fibrillation. Apparently does not have a pacemaker, because when I see anticoagulants for atrial fibrillation, first thing I ask is, do they have a pacemaker? He has MRI showing small vessel ischemic change, 4 microhemorrhages, 1 area of superficial siderosis, and 1 lacunar infarct. So I have to tell you, this patient is kind of right on the fence, right? Has anticoagulation, has microhemorrhages, has superficial siderosis, has a lacunar infarct. And so you got to think about whether this guy could be relevant, because this patient might be right on the fence, meaning there's a lot of things going on that would exclude him, but he's not technically absolutely excluded. So the absolute exclusions are more than 4 microhemorrhages, macrohemorrhages, severe white matter disease, severe superficial siderosis, et cetera. So I have to tell you, based on this patient, the patient's right on the fence. And we have to worry, of course, about the possibility that the patient could get ARIA-E and ARIA-H. So this is one of those ones I would try, number one, to get him off of his anticoagulation, try a Watchman. I've actually sent a lot of patients lately to get Watchman devices to treat their atrial fibrillation. 2 is I would have a long discussion with them about the risks and the benefits, and then we'll go from there. So the question is this patient eligible for ATTs? I've already given you a lot of considerations, and because he's at high risk for ARIA, the upper middle part of this slide is that the baseline ARIA findings indicates a higher risk for ARIA. And so the question is, what do we decide to do? Again, shared decision-making. After weighing the potential risks and benefits of treatment and considering his personal risk factors and medical comorbidities, Kendrick and his physician decide against initiating treatments with monoclonal antibodies, the anti-amyloid therapies. This is a reasonable choice. I think that's a good example of shared decision-making. This is a person I might consider a clinical trial to as an alternative. So our next case is an 80-year-old male. His name is Max. After receiving biweekly infusions of the monoclonal antibody anti-amyloid therapies, he comes in for his routine checkup for his MRI, and it shows that he actually has some evidence of ARIA. So routine safety MRI detects 6 microhemorrhages, 2 areas of hyperintensity in the left frontal lobe, indicating moderate ARIA-E and ARIA-H. He is clinically asymptomatic. So this is super, super, super important. What you have to understand as an audience is that most ARIA events, more than 80%, whether you're talking about lecanemab or donanemab, most ARIA events are clinically asymptomatic, meaning the only reason you even know about them is the MRI shows them, but only 6% are symptomatic or severely symptomatic. So I want to tell you that most of the time we do the routine monitoring. In a situation like this, I might just stop it for a few more treatments and think about redosing. But the bottom line is this patient has some evidence of ARIA, and so the appropriate thing is, again, stop it, and then I would scan him until the ARIA imaging resolves. If you commit to using the monoclonal antibodies, you have to do a lot of surveillance and screening for ARIA, and this includes MRIs frequently. You cannot get away with CTs as surrogates. With lecanemab, the schedule is on the left bottom. On the left, you do them after the 5th, 7th, and 14th infusion. On the right, it's 2nd, 3rd, 4th, and 7th infusion. Donanemab is once a month infusion. Lecanemab every 2 weeks infusion. MRI should be done at baseline prior to initiating treatment. You would hold the infusions if there are any ARIA considerations. You can actually dose through if it resolves. That's an individual decision. You don't have to stop them permanently. You can always redose as a consideration. So signs and symptoms that you should be aware of is headache, confusion, dizziness. Only one patient of mine had symptomatic one, and you could tell he was just off. He was confused. He was really out of it, a little disoriented. We were doing a telemedicine visit, and I said, you need to go to the emergency right now. And sure enough, he was admitted to the hospital. So that's 75% are asymptomatic, 25% are symptomatic, minimally only 6% are severe. And these are the list of things you need to look for. So ARIA-E and ARIA-H, you have to consider the clinical characteristics. Some of them you got to look at the radiographic characteristics. When I'm looking at ARIA-E, I look for vasogenic edema, mostly on the posterior aspect, mostly in the parietal occipital regions, and mostly on the periphery at the gray-white matter junctions, as you see here. So there's meningeal infusion in several sulci in the medial temporal lobe, or the right temporal occipital lobe, or parenchymal edema. So this is just a vasogenic edema, right? So it's intravascular fluid and protein into the parenchymal interstitial fluid compartment, and that's the kind of thing you look for. Microhemorrhages have to be looked at on the GRE. Some people look at them on the SWI, which is an overinterpretation. And so you need to look for blood degradation products adjacent to the parenchyma and in the subarachnoid space. The MRI criteria for characterizing radiographic severity is mild, moderate, severe. And these are the criteria. There's a scale. There's a couple of scales, 1 to 3 or 1 to 5. To be clear, not only is most ARIA clinically asymptomatic, but most ARIA is radiographically mild, meaning the 1 and 2s, mild and moderate. Very few of them are severe, and they are defined in this slide. If you have a lot of intensity, more than 10 centimeters of hyperintensity, you really got to check on the patients clinically. And if you have a lot of microhemorrhages, that would be something to worry about as well. The way you manage ARIA is by selecting your patients very, very carefully. So I have found that if you screen them carefully, make sure they have 0 or very few microhemorrhages, that they, of course, can get MRIs, that you follow the labeled schedule for lecanemab and donanemab, and you should check it yourself. So I actually check all my MRIs. I have all my reports comment on them on the ARIA-E or ARIA-H. And when I see any ARIA, I call the patient and see if they're symptomatic or asymptomatic. If they're asymptomatic and their ARIA is present, I will hold it and then consider routine MRIs until the ARIA resolves, and then I'll consider whether I'm going to redose. If it's severe and symptomatic, then I probably might not redose, but I will continue to check them. And sometimes if it's severe, I might even admit them. So I will tell you that these are the stopping criteria, and this is the management algorithm. So everybody's a little different when it comes to resuming treatment after resolution of ARIA. ARIA symptoms and radiographic ARIA-E changes must resolve before considering restarting the amyloid-related therapy. Decision to resume therapy should be based on a discussion of risks and benefits with the patient and care partners, as ARIA could recur. Further considerations regarding ARIA management and whether to resume treatment includes the severity of ARIA radiographic changes, the presence and severity of any symptoms, the patient's APOE genotype, or morbidities and con meds. And so we stopped it, and we did MRIs, as you see on the bottom, every 2 months. It resolved, and the ARIA-H stabilized over the span of 6 months, and the shared decision-making was to resume treatment. So in conclusion, amyloid treatment therapies represent an exciting advancement in the care for patients with Alzheimer's disease. The clinical diagnosis of mild cognitive impairment or mild dementia due to Alzheimer's disease is needed to determine if they are eligible for anti-amyloid-related therapies. Biomarker confirmation of AD is also necessary for monoclonal antibodies. Careful patient selection and safety monitoring are critical to successful utilization of these new therapies. Benefits and risks of amyloid-related therapies should be discussed with patients and families. Care teams with appropriate infrastructure and communications are needed for ATTs to roll out, and ARIA monitoring and management is critical. And with that, I thank you for listening.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant by Eisai Inc. To access all materials for this activity, visit peerview.com/NMQ860.